Hi everyone. Hi, my name is Ruth. Thank you for joining us at APICS 2020 this morning. And we apologize once again for all the technical difficulties that we have faced today. All these talks by our three speakers today will be pre-recorded and recorded and uploaded to our website as soon as possible. So moving on, this is a special track today we have on critical care cardiology. We have three invited speakers who will be sharing with us key topics on their experiences in this very exciting field. So during this session, if you have any questions for the attendees who are with us this morning here in Singapore, you just put your questions in the Q&A app in the Zoom at the bottom, and we will address all these questions at the end of this session, which should last about about 1.5 hours. So without further ado, I'm very happy to welcome our first speaker who is joining us all the way from USA. It's 12 hours at night over there. Prof. Katz. Prof. Katz is a cardiologist, advanced heart failure specialist, and critical care specialist. He is also the director at Duke Health, North Carolina for cardiovascular critical care, as well as the co-director of the cardiac intensive care unit and the mechanical circulatory support program. Prof. Katz has helped to galvanize the field of critical care cardiology around the world. His research centers on optimal care delivery within the contemporary cardiac ICU, management of cardiogenic shock, and the effective employment of temporary and durable mechanical circulatory technologies. We are very honored to have him with us today, and he'll be discussing on the management of cardiogenic shock and generating and applying evidence during this COVID-19 era and beyond. Prof. Katz, please. Yeah.
Great, thank you. I'll pull up my slides here.
Thank you, Prof.
Just be 1 second. Can you see them okay, Ruth?
Yes, we can see your slides very well and can hear you very well too.
Great. Well, first of all, thank you so much for the warm introduction. It's nice to be participating in this great conference, although to be honest, I wish I was there in person. Instead, I'm here in the middle of the night in North Carolina in my living room. But nonetheless, 2020 is an interesting year and we make things work. And I'm excited to be participating in this great discussion. So I've been tasked with discussing cardiogenic shock management. And then specifically, I'll talk about what we have learned about cardiogenic shock, things that we've learned more recently within the COVID era, things that are specifically perhaps related to the COVID era, and lessons that we've learned that will hopefully be durable lessons that we can continue to use to grow our understanding of cardiogenic shock management. So I have no financial disclosures to mention that are relevant to this discussion. I think this is a great quotation from Charles Darwin that I think sets the stage nicely for this type of discussion. It is not the strongest of species that survive, nor the most intelligent necessarily, but the ones most responsive to change. And if COVID-19 and 2020 and even the technical difficulties of this APICS conference this morning tell us, is that we have to be malleable or adaptable or agile and willing to change. And I think that's reminiscent of what we need to be doing in cardiogenic shock management. So we know a lot. This is just a few of the headlines here in North America highlighting the potential injurious nature of COVID-19 when it relates to heart injury. And we've seen numerous potential manifestations from a cardiac perspective, any one of these that can lead to cardiogenic shock and find COVID patients needing cardiogenic shock management, including mechanical circulatory support, things such as acute fulminant myocarditis with shock, acute coronary syndromes, stress and sepsis-induced cardiomyopathies, acute right ventricular failure, sudden cardiac arrest. These are just a few of the potential cardiac manifestations that are relevant to this discussion on cardiogenic shock. So we'll start a little bit from a didactic perspective about what we know about recognizing cardiogenic shock, and we'll bring in examples from the COVID era and hopefully discuss how we can move the field forward. So if you were going to Google shock as a term, you might find any number of definitions. But of course, we want to particularly focus on the medical definition you'll see in the bottom in red, and in which there's a collapse of circulatory function caused by severe injury, blood loss, disease, that's characterized by manifestations of hypoperfusion and tissue hypoxemia, and oftentimes associated with a very low blood pressure. It is more specifically the physiologic state characterized by a severe reduction in tissue perfusion that results in decreased tissue oxygen delivery, cellular hypoxemia, and then the microscopic and macroscopic effects of tissue hypoxemia, including a number of manifestations you see on the right side of the slide: ion pump dysfunction, acid-base disturbances, dysfunction of the endothelium, cell death, and then on a broader scale, multi-system organ failure, and ultimately patient death. Systemic perfusion, of course, is governed by two things: cardiac output and systemic vascular resistance. And in shock, one, or in many cases, both of these are significantly impaired. Your cardiac output, of course, is defined by a heart rate times the stroke volume and is related to loading conditions, preload, afterload, contractility, and chronotropic competence, to name a few. Whereas systemic vascular resistance is related to features of the vessel itself and the flow dynamics, things such as vessel length, the blood's viscosity, the diameter of the vessel, vascular tone, and other things. So what is cardiogenic shock then? We've talked about what shock is, but cardiogenic shock, if we were going to define it broadly, would be a low cardiac output state leading to end organ hypoperfusion, tissue hypoxemia, and its sequelae. So simple, right? You'll know it when you see it. And I think the next several slides will suggest that maybe it's not quite as simple as this definition might lead us to believe. So what are some of the physical manifestations of cardiogenic shock specifically? Well, you may have a patient with altered mental status due to cerebral hypoperfusion. The neck veins will often be elevated as a consequence of elevated cardiac filling pressures. Patients may be tachypnic due to either pain, pulmonary edema, or a response to a progressive metabolic acidosis. They're oftentimes tachycardic as a first compensatory response to a low stroke volume. They are often hypotensive and may in fact have a narrow pulse pressure. They may have markers of end organ dysfunction, such as elevated liver function tests, elevated BUN or creatinine. Their extremities tend to be cool as a marker of increase in systemic vascular resistance. They may have signs of hypoperfusion from a tissue perspective, such as livedo reticularis. But it's oftentimes not quite that simple, and we've found and learned over the years that there are oftentimes multiple phenotypic and hemodynamic presentations of cardiogenic shock, which makes it complicated to recognize and treat the shock patient. Not everyone has classic cardiogenic shock, where there'll be a low cardiac output or cardiac index with elevated wedge pressure and a high systemic vascular resistance. And in fact, from the early days, from the original shock trial and registry, we know that about a quarter of patients that present with cardiogenic shock complicating acute MI may have mixed shock or a vasodilatory component to their cardiogenic shock. And in fact, we've seen this as well with COVID-19 related cardiogenic shock in its many forms. We also know from epidemiologic studies and cross-sectional surveys such as this one from the Critical Care Cardiology Trials Network, a large registry of now nearly 30 sites within North America. This particular figure highlights the landscape of shock within the contemporary cardiac ICUs of North America. And you can see in particular from the slide, the figure on the right, most of actually what we're seeing in our contemporary cardiac ICUs is no longer acute MI associated cardiogenic shock, but rather cardiogenic shock from a number of other potential reasons, including progressive underlying chronic cardiomyopathies. So while most of the trials we're looking at are focused on populations of patients with acute myocardial infarction and shock, in fact, we're seeing those patients as the minority of those occupying our contemporary cardiac ICUs. This is in North America. I'm not entirely sure what you're necessarily seeing in Singapore, but I think, in general, the face of cardiogenic shock has evolved. I show this slide almost every time I talk about cardiogenic shock. I think this is kind of a job security slide. It highlights how complicated cardiogenic shock can be, how many different pathways are impacted by acute left ventricular systolic and diastolic dysfunction. And I think in general, this suggests that no organ system is safe because of the many manifestations of shock here. And to be sure, cardiogenic shock is now a multi-system injurious process. Fact, about 78 to 88% of patients with cardiogenic shock will require some form of mechanical ventilation, most commonly invasive mechanical ventilation. Fact, acute kidney injury complicates up to a third of patients with cardiogenic shock, and 1 out of 5 will need renal replacement therapies. Fact, up to half the patients will have evidence of ischemic hepatitis or some form of hepatic dysfunction. And one more fact, delirium or altered mental status is seen in 30 to 78% of cardiogenic shock patients, stroke as well. So now that we've talked about identifying and trying to vet the cardiogenic shock patient, how about triaging and risk stratifying the cardiogenic shock patient? Well, these are various definitions that have been used in contemporary clinical trials of cardiogenic shock, and you can see these are quite varied. Some will use a definition of protracted or prolonged hypotension, maybe defined as a systolic blood pressure less than 90 over 30 minutes. Some will require the use of catecholamines to maintain systemic perfusion. Some will highlight some markers of end organ hypoperfusion, which you see here. Some will ask for pulmonary congestion. Some, although very few, require a hemodynamic definition of cardiogenic shock, including a depressed cardiac index or elevated pulmonary capillary wedge pressure. And some clinical trials utilize various laboratory criteria suggestive of end organ dysfunction and tissue hypoxemia. More recently, the SKY Shock group came up with this criteria, an ABCDE classification of cardiogenic shock. And while this is a polarizing risk stratification method, and it is a bit challenging to use in clinical practice and for research purposes, what I think it did quite well is to show that there are gradations in severity and presentation for cardiogenic shock patients. So not every cardiogenic shock patient presents the same way. Some will have early manifestations of cardiogenic shock, while others will have multi-system organ failure and require immediate support prior to cardiac arrest. So I think what this highlights, the various definitions of cardiogenic shock in clinical trials, the various gradations that have been recently incorporated into the contemporary literature, is that there's a real need to understand and find a common language for discussing cardiogenic shock patients. And until we do that, we really will undermine our research efforts, will undermine the opportunities to identify metrics of quality, will not be able to communicate with each other as teams, and will not be able to leverage shock networks as effectively as possible to manage shock patients. So one really important point that I think has been driven home by the COVID-19 pandemic and shock that's been associated with that is that we really need to figure out how to speak the same language and talk about these patients in a common form. So what do I think about when I'm triaging these patients? I go back to this old 2x2 table popularized by Lynn Warner Stevenson in the very early 2000s, risk stratifying patients with acute heart failure based on cardiac output and cardiac filling pressures, in this case, wedge pressure. And we're really talking about these patients that have low cardiac output who may or may not have elevated cardiac filling pressures, these patients that are cold and who may be wet or dry, the patients that are often going to need IV vasoactive medications or in some cases mechanical support. So how do I determine who is cold? Well, besides feeling the patient, particularly their shins and forearms, there are other non-invasive ways to do this, including measuring the pulse pressure, or in this case, a proportional pulse pressure, which is the systolic pressure minus the diastolic pressure just divided by the systolic blood pressure. And in this case, a proportional pulse pressure less than 25% fairly well predicts a cardiac index that is low. But warning to all, in these patients that are increasingly having mixed shock states, this is going to be a confounding variable. So the pulse pressure or the proportional pulse pressure won't work as well in patients that have concomitant vasodilatation. What about how would I determine how patients are wet? Well, when they're profoundly volume overloaded, when they've got pulmonary edema, when they're sitting up straight because they can't breathe in a supine position, that's easy. but some of these patients won't have as marked an evidence of volume overload despite being quote unquote wet, particularly those who have chronic cardiomyopathies and an augmented a lymphatic drainage system. So the presence of crackles, for instance, is quite specific, but not necessarily sensitive in patients that have chronic myopathies. What about ischemic? People always ask this all the time. So we have a lot of data on acute MI management of cardiogenic shock, but not everyone obviously comes in with acute ST elevation myocardial infarction. And oftentimes people want to risk stratify patient based on the presence of ischemia or not. Does your patient have an ischemic myopathy? Do they have a non-ischemic myopathy? And should we be managing them differently? And I think a good way to sort of highlight this or illustrate this phenomenon is to look at the perfusion pressure gradient. And every end organ vascular bed has a perfusion pressure gradient. Blood travels down a perfusion pressure gradient, and the coronary bed is no different. So the coronary perfusion pressure is defined by the aortic diastolic pressure minus the pressure in the left ventricle, in this case, the left ventricular end diastolic pressure. So here's a couple of examples that I think will highlight what I'm about to get to. So in a normal patient who may have a blood pressure of 120/80 and an EDP of 12, the coronary perfusion pressure is quite high. There's not the risk for myocardial ischemia because you're driving blood at quite a high perfusion pressure across the myocardium and subendocardium. In early cardiogenic shock, perhaps stage B or C of the new SCAI criteria, your patients may have a lower blood pressure, 85/50. The LV-EDP may be marginally elevated, but even with that, the coronary perfusion pressure has dropped by almost half. Now imagine a more advanced cardiogenic shock patient who might have a blood pressure of 85/50 and markedly elevated cardiac filling pressures. In this case, now you have a coronary perfusion pressure as low as 15 millimeters of mercury. So whether the patient has obstructive coronary disease or not, they now have a low coronary perfusion pressure and the myocardium is at risk of ischemic events, including this one. So my answer for all the people that ask me when a patient comes in profound cardiogenic shock is that they're all susceptible to ischemic manifestations when they're really, really sick. What have we also learned recently in the contemporary COVID era? Well, we've had a resurgence of some technologies for sure. In the late 1990s, early 2000s, the pulmonary artery catheter was left for dead. People stopped using it because there wasn't good data to support its use in general critical care cohorts. But there has been certainly a resurgence in cardiogenic shock management, such that the American College of Cardiology and the American Heart Association give the use of pulmonary artery catheters a class 1A indication for cardiogenic shock. And a lot of this is being driven by the use of temporary and durable mechanical circulatory support devices. So it's helpful to understand the cardiac filling pressures, how well or how poorly you're unloading the ventricles, and what the improvement or lack of improvement in systemic perfusion is. And the pulmonary artery catheter, like many things we learn in the ICU, can be a helpful adjunct. But there are still lots of questions that require answering. And research initiatives, particularly cross-institutional and multinational collaborations, will help to answer some of these questions. In particular, how we can use the pulmonary artery catheter more specifically to reach quality metric targets for our heart failure and cardiogenic shock patients. How should it inform our initiation of temporary mechanical circulatory support? How can we use it to inform escalation and de-escalation of MCS therapies? What are the ideal targets for our patients? Should we have a general guideline, or should they vary depending on the patient? And are absolute numbers important, or, as I would suggest, are trends more important to follow? And many, many more questions that remain unanswered. And this is kind of part of the problem here. This is, again, from the Critical Care Cardiology Trials Network, looked at the use of pulmonary artery catheters across high volume institutions in the United States and North America, and looked at the use of pulmonary artery catheters among cardiogenic shock patients. And despite looking at a number of potentially explanatory variables, only one variable stood out as an independent predictor of PA catheter use, and that was clinical site. Again, sort of suggesting that it's really physician or institutional preference that's driving PA catheter use, and not necessarily features related to the patient or their disease presentation. So again, lots to learn. Clinical gestalt and physician preference right now is still driving predominantly the use of PA catheters. How about now treating the shock patient? So, we have a veritable alphabet soup of temporary mechanical support technologies that we use. In many institutions, particularly in North America, we see any number of these devices for left ventricular, right ventricular, or biventricular support, including balloon pumps still, the use of the centrifugal flow tandem heart device, the axial flow Impella platform of devices, a number of different RV support technologies, including Protect Duo, and an increasing use of extracorporeal membrane oxygenation for cardiogenic shock use. And it's enough options to drive you mad. It's really can be challenging deciding what to choose and what to choose for which patient. So what do I suggest? I don't really have great head-to-head data to really guide you in this decision-making process. But what I have learned, if anything, and I think probably most of the people on this meeting could probably attest to this, is sometimes in the intensive care setting, the more choices you have, the less likely you are to get things done. So I think everyone should obviously look at themselves in the mirror, understand what their resource commitments are at their own institution, and probably be good with a number of different strategies, but not necessarily good at every single one of them. It's important to underscore the fact that, while there's a lot of observational data supporting the use of some of these technologies for cardiogenic shock, there are no great head-to-head trials and certainly no robust randomized controlled trials driving the use of these therapies. Although it hasn't stopped us from using it, the rates of use of temporary MCS across the world have increased dramatically, particularly over the last 5 to 10 years. I also believe very strongly in a less is more approach to critical care in general. I think our job as intensivists is to take a patient that's critically ill and decompensating, provide whatever therapies they need to stabilize them and achieve some form of sort of reasonable homeostasis, and then largely get out of the way to see if the patient gets better on their own. So you do enough to stabilize the patient, but never sort of in the history of medicine is doing extra work for the patient, trying to outsmart the body a good thing. So I think about a strategy based on a number of variables that you're given, clinical hemodynamic variables, what your institution might have and what you're good at employing, device efficiency, et cetera. We place the devices, and I think it's really important to take time to assess from a serial perspective how a patient is responding before necessarily sending them back to the ICU or closing the door to their room and walking away. And I think preparation is the key. Being prepared to escalate care as necessary, being prepared to adjust support strategies as necessary, being prepared to deal with adverse events, which are all possibilities with these devices. And I think really it's important to work as a team. And again, a final picture from the registry of the Critical Care Cardiology Trials Network again shows the variation in the use of temporary support devices across institutions. Institutions have variable expertise and experience with different devices. And again, without head-to-head trial data, I think it's sort of dealer's choice. People can use whatever they're comfortable with. So what specifically has COVID-19 taught us about managing cardiogenic shock? Well, I think, as I mentioned very early in this discussion, it's taught us to be agile. It's taught us to be malleable. It's taught us to be okay with modifying and even simplifying strategies of care for cardiogenic shock and critical illness. This is an example of how routine STEMI care may be adjusted due to the COVID-19 pandemic. I was fortunate enough to work with a number of international co-authors on a paper that was published recently in JACC, identifying potential disruptive modifications to how we deliver cardiac critical care as a complication of the COVID pandemic, highlighting the critical care cardiologist as perhaps the conductor of a bunch of therapies for patients with acute cardiac illness and in particular cardiogenic shock, to help facilitate point of care imaging studies, to help manage cardiac arrest when patients need to be isolated or PPE is limited, the use of cath procedures or other invasive procedures, including operative interventions, and again, the application of mechanical circulatory support in a way to decrease the potential infectious complications, and to strategize a mechanism for employing people in light of the pandemic demands. We talked about staging critical care delivery, and this is applicable to the cardiogenic shock patient, particularly as surge capacity changes. Leveraging, being agile, again, to change nursing to patient ratios, being agile enough to utilize different participants in cardiology, being agile enough to utilize network hospitals to perhaps repatriate the less sick patients to focus on the more sick patients in higher volume, more experienced centers. And other organizations like the Extracorporeal Life Support Organization had similar recommendations in terms of surge capacity, dictating how institutions might deal with the need for ECMO. It all sort of brings back to focus the need to sort of understand how a pandemic like COVID-19 might change the inclusion or exclusion criteria that you and your institution may apply to patients in cardiogenic shock or those that need mechanical circulatory support. Again, I mentioned this earlier. If you're part of a network, which many of us are in North America, there's opportunities to leverage network hospitals to care for some of the less sick patients while focusing on the higher risk patients, particularly those in cardiogenic shock and those that need mechanical circulatory support, to the level 1 tertiary care or quaternary care hospital that can provide those type of therapies and expertise at the bedside. And again, I think one thing that COVID-19 has forced us to do, and something that we should have been doing for a long time in the management of cardiogenic shock and critically ill patients in general, is to better understand critical care futility. And I think we still have a long way to go to understand that, but we've certainly been seeing the use of palliative care providers as partners and team members in the care of shock patients escalate over time. And the COVID-19 pandemic has made that even more critical. And then another thing that's been really unique, at least in North America, and I suspect around the world, is the fact that COVID-19 has caused many of our patients, particularly those that are older with more comorbidities, to avoid the hospital even when they're presented with acute clinical manifestations of cardiovascular disease, such as acute MI. And we've been trying to get the message out that patients shouldn't stay at home and deal with their symptoms, but rather present to the hospital. But as a consequence, we've seen, and I've seen personally, a lot more of the complications that I thought were relics of an earlier time of cardiovascular disease, but now we're seeing with increasing frequency because of late presenting myocardial infarction, such things as free wall rupture and papillary muscle rupture and cardiac tamponade complicating acute MI. And it's caused us to sort of try to redefine our systems of care, particularly our partnerships with cardiac surgery and interventional cardiology and critical care team members, as well as palliative care team members, to manage these complications of acute myocardial infarction. And then nearing the end here, I'll say, teams are, I think, very important for managing the cardiogenic shock patient. Teams are very important in critical care cardiology in general, but why particularly for cardiogenic shock? Why particularly in the COVID-19 era? It's because cardiogenic shock is a high-risk condition where time matters and multidisciplinary care is absolutely needed. And it is also a resource-intensive clinical condition. There are many examples in acute care medicine of a successful employment of teams, traumas, rapid response therapies, cardiac arrest in our operating rooms. And I think the employment of teams in cardiogenic shock, and particularly during the COVID era, have become fairly crucial. And while I can't say we're necessarily experts in the team management of cardiogenic shock in a structured format here at Duke, there are others, colleagues around the country, like this group of gentlemen from Inova, who've really defined the use and popularized the use of cardiogenic shock teams, and have been able to become more malleable and agile and adapt their algorithms, particularly for potentially infected patients with the SARS-CoV-2 virus. So there's a lot left to learn. And one thing that I think is really missing is that there are no guidelines to really drive our management of cardiogenic shock. One time I was asked to give a talk, and the question was, what is missing from the cardiogenic shock guidelines? And my answer to that question is the guidelines themselves. We still are missing cardiogenic shock guidelines, so we really need to inform the management of patients through multidisciplinary, multi-institutional, and multinational efforts. And that is something that will be really important to help guide cardiogenic shock care from COVID-19 and for many, many years moving forward. And then I think it's also important to remember that just because we've been safely pulled from the water, you get a patient with cardiogenic shock that comes to the emergency department and is supported with a mechanical device, and you wipe your brow and feel good about yourself and start to walk away. Well, you're just getting into the troubles. And so in this picture, which I happen to like, this gentleman's being pulled safely from the water, and then the shark jumps out and grabs him. So just when he thinks he's safe, just when we think we've gotten the right device to the right patient at the right time, there are many questions to answer. Are they getting enough support? Is it time to escalate, or can we de-escalate support? Do we need to transition to a durable mechanical support strategy, or is there hope for cardiac recovery? What about the use of a number of different support tools and monitoring tools, and things like ECMO venting? When do we need it? When do we not? So lots of questions for the management of cardiogenic shock. And we're starting to see the emergency use of some of these therapies that are being approved by, in the United States, the Food and Drug Administration, such as the Impella platform of devices that have been specifically approved as a venting strategy for our ECMO patients due to COVID-19. And then finally, I think this is the last slide. It's not enough to get the patients into the ICU and keep them alive, but we have to think even more broadly. This disease has a long-standing influence on patient outcomes, and those occur even after the patient leaves the ICU, even after the patient leaves the hospital. And so many things can occur when the patients are trying to be transitioned to home, particularly in the early phase after discharge. The highest risk of death after cardiogenic shock in survivors is in that first 60 days after discharge. Quality of life is substantially impacted early after discharge. 1-year all-cause mortality and heart failure hospitalizations are increased substantially early after a cardiogenic shock hospitalization. So if we fail to focus on those characteristics of the patient's journey, we are doing our patients a disservice. So I'll finish up with yet another quote. I started with one and I'll end with one, and I think this is quite descriptive of particularly the first line healthcare workers that have really sacrificed themselves for the care of our patients. And this quote is, I think, quite descriptive. Out of the suffering have emerged the strongest souls. The most massive characters are seared with scars. And many of us now have scars as a complication of COVID-19. But these scars are going to help to inform our future practice, and we'll learn from them. And I think our patients will ultimately be better off because of the lessons we've learned together in managing patients within this pandemic. So I'll thank you right there. And I think I appreciate the invitation, and thanks for bearing with me here this morning.
Thank you very much, Professor Katz. Thank you very much for that very, very comprehensive talk on cardiogenic shock and emphasizing the focus on coronary perfusion pressures and the various invasive and minimally invasive methods so we can monitor these hemodynamic parameters. And of course, reminding us that the patient's journey does not just end upon leaving the ICU, but how can we look at other devices that can take these patients even after they have recovered from heart failure. We will leave the questions towards the end of this session. We have 2 more speakers who's coming right up. So without further ado, I'd like to introduce our second speaker, who is a familiar name on the local critical care medicine scene, Dr. Chia Woon. Dr. Chia Woon is our cardiologist and intensivist and the director of the Cardiac Intensive Care Unit at Tan Tock Seng Hospital in Singapore. His diverse expertise include hemodynamic monitoring, mechanical circulatory support, and critical care ultrasound, for which he's a leading educator in all these areas. Dr. Chia also heads a successful post-cardiac arrest care program and is a faculty member in many of the region's cardiac arrest and ECMO courses. He is also the chairman of Singapore's National Targeted Temperature Management Work Group. Today, Dr. Chia will be talking to us about heart-lung interactions. And in this talk, we will divert our attention slightly away from COVID-19 and look at how we manage ARDS. Hypoxemia and hypercapnia are often present in ARDS, and interventions to optimize oxygenation and ventilation may not always be successful and may be associated with hemodynamic instability. So may I now welcome Dr. Chia, who will be discussing the intricate role played by the right ventricle in cardiorespiratory physiology. Dr. Chia, please.
Thank you. Good morning, everyone. Thank you very much for the very kind introduction and the kind invitation from the organizers. I got no disclosures related to this presentation. So in this talk, we shall review the unique anatomy and physiology of the right ventricle. We will cover the important heart-lung interactions during mechanical ventilation, the diagnosis of acute cor pulmonale, and the key management principles. Let's start with a case. So it's a middle-aged gentleman with no significant past medical history, presented essentially with cough, fever for 3 days duration. So in the ER, he's clearly febrile, have a borderline blood pressure, have a high respiratory rate, and clearly in a respiratory distress. So the labs came back as a high white cell count, evidence of acute kidney injury, and hyperlipidemia. So this patient was emergently intubated for respiratory distress. This is X-ray after intubation. It shows widespread airways shadowing, and I think that is consistent with a severe community-acquired pneumonia. And in the current era of COVID-19, I think that patient will need to be isolated and for some swabs to be performed. So in the ICU, there's thick yellow secretions. In terms of oxygenation, it's still poor, despite a P of 10 and FiO2 of 80%. The CO2 remains high, despite a tidal volume of 7 mL per kg and respiratory rate of 25. In fact, the Pro2 pressure is already 28 cm water. In terms of circulation, the MEP remains low, despite 1 liter of crystalloids and norepinephrine of 0.5. And urine output is minimal. And patient is currently sedated and paralyzed. So I guess the question is that what do we do next in terms of the ICU management? So the team chose to do some lung recruitment maneuver and park the PEEP at 15 cm water, and in an attempt to clear more carbon dioxide, increase the minute volume by increasing both the tidal volume and the respiratory rate. And in view of hypotension, patient was found to be fluid responsive based on pulse pressure variation of more than 15%, and was given another liter of crystalloids, and norepinephrine was also increased to 1.0. So this is what we had at the start of the ICU, and then this is what we have done all the interventions, and this is what we found. The MEP did not really get much higher despite all the interventions. In fact, the cardiac index seems to have dropped, and the right atrial pressure actually increased despite a fluid bolus. It actually went much higher. This may suggest some degree of RV dysfunction, and the stroke volume variation actually increased with a fluid bolus and not decreased, which is what we expect. So what's happening to this patient? I think in the ICU, it's not uncommon that our usual treatment strategies of fluid infusion, vasopressors, high PEEP, doesn't change the patient's outcomes, and the parameters fail. So we need a strategy to find exactly what's wrong with the patient. It's been shown that in undifferentiated states in the ICU, especially in shock, ultrasound is very helpful because it helps us to differentiate hypovolemia, cardiogenic shock, obstructive shock, and also differentiate distributive shock. This is an oversimplification, however, as more than one pathology process may coexist in a critically ill patient. Nonetheless, this is what we found for our patient. There's a parasternal long axis view, parasternal short axis view, and the apical 4 chamber. I think it's quite clear from these 3 images that there's evidence of right ventricle dilation, because the right ventricle end diastolic area is much bigger than the left ventricle end diastolic area. There's also evidence of paradoxical septal motion, and together they suggest the presence of what you call acute cor pulmonale, or acute right heart failure secondary to high afterload. The incidence of acute cor pulmonale is very high, about 60%, before the common use of lung protective ventilation strategies. But even in the current era where many patients are on pressure-limited positive pressure ventilation, the incidence of acute cor pulmonale is still quite high, about 25% of patients. Therefore, there are many studies trying to figure out what are some of the predictive factors that can result in acute cor pulmonale, including pneumonia, driving pressure more than 18 cm water, PF ratio less than 150, or PaCO2 more than 48. It's been shown that if you score 2 or more points, then the chance of acute cor pulmonale occurring is much higher. And therefore, if you score 2 or more points, routine echo has been recommended. I just want to point out specifically about hypercapnia. Because in this era of lung protective ventilation strategies, permissive hypercapnia has been encouraged. But we understand that when you do permissive hypercapnia, CO2 increases, and there's a chance that the high CO2 may actually contribute to your pulmonary vasoconstriction and also increases your right ventricle afterload. We go through anatomy and physiology of right ventricle next. So right ventricle is a crescentic shaped structure that hugs the left ventricle, and it shares a same interventricular septum, common myocardial fibers, and also within the same pericardial constraint as the left ventricle. And this is very important when we discuss about ventricular interdependence later on. And this very complex geometry of the right ventricle will make the quantification of both the size and the function more challenging. This is a very commonly known venous return graph. You can see that the venous return will correlate with the right atrial pressure. At the higher right atrial pressure, your venous return actually drops. And that's because venous return is equal to mean systemic filling pressure minus off your right atrial pressure divided by your resistance to venous return, which is in the slope itself describes that relationship. And your right atrial pressure increases to the same level as a mean systemic filling pressure. That's when your venous return becomes 0. And therefore, the right ventricle actually is highly compliant. It fills out very well with volume with very little rise in the pulmonary with the right atrial pressure, and pumps blood into the highly compliant pulmonary circulation. So it's a very low pressure system in the right heart. This is another very important physiological relationship. You can see that as the pulmonary artery pressure increases, there's a very rapid drop in a right ventricle stroke volume. So the right ventricle is very sensitive to high afterload, especially an acute rise in the pulmonary artery pressures. So something to remember. So this very simplified graph describes the right ventricular and the pulmonary artery coupling and the pressure volume loops. So when the tricuspid valve opens, there's rapid filling of blood from the right atrium to the right ventricle. At the end of diastole is isovolumetric contraction. When the pulmonary valve opens, there's a rapid systolic ejection of blood. At the end of systole, there's isovolumetric relaxation. What important is that the end systolic pressure over end systolic volume describes what you call the end systolic elastance of the right ventricle and correlates with the right ventricle contractility and systolic function. And we'll describe that later on again. And the slope of the end systolic pressure divided by stroke volume describes what we call the effective pulmonary arterial elastance, which is also consistent with the right ventricle afterload. And the ratio of the end systolic elastance divided by the arterial elastance ratio is what we define as optimal RVPF coupling with a ratio of 1.5 to 2.0 as being important. So pathophysiology of heart failure, we need to remember 2 of the important laws. So AMRAP law suggested that a heart adapts to increased afterload through an increased contractility or homeometric adaptation. The Starling's law described that if increased load to the heart is increased in the dimensions of the heart by what I call heterometric adaptation. So first and foremost, when it's a high right ventricle afterload, there's going to be increased afterload to the heart, and that result increased cardiac contractility by homeometric adaptation to preserve right ventricular to pulmonary artery coupling. If that fails, there's going to be increased end diastolic volume by heterometric adaptation to preserve flow output, but can cause altered ventricular indirection, as we shall describe later on. So it's a very important flow volume loop that describes that relationship. You can see from here, this is going to be your right ventricular afterload, and this is going to be your right ventricular contractility. So it maintains an EES over EA ratio of 2.0. But if it's going to be increased in terms of your pulmonary artery resistance, there's going to be a concomitant increase in your right ventricular contractility in order to preserve an EES over EA ratio of equal to 1 or close to normal. Similarly, on another chart, you can see that this is a normal right ventricular contractility. When it's going to be a pressure overload state, for example, increase in your pulmonary vascular resistance, the right ventricular contractility will increase. This is based on what I described earlier on by the AMRAP law. However, when decompensated pressure overload occurs, there's a drop in your cardiac contractility, and you can see an increase in your right ventricular end diastolic volume. So that's why it happens in a very graphical way on a CAT scan. So there's preserved right ventricle PA coupling initially by increase in inotropy, and therefore there's no evidence of right ventricle dilatation. However, with time, there's going to be filling of the right ventricle to pulmonary artery coupling process, and there will be heterometric adaptation, and that's when the RV will dilate, and they'll result in ventricular interdependence phenomenon that we'll describe later on. So it's also been shown also that most of the right ventricular coronary blood flow occur mainly in systole, as you can see from this chart, as opposed to the left coronary artery that perfuse mainly in diastole, as alluded on earlier on by the earlier speaker. So systemic hypotension, or where PASP is more than SBP, will result in RV ischemia. And therefore it's very important for us to defend and preserve your systemic blood pressure. Because any further reduction in blood pressure will result in ischemia to the right ventricle, further reduction in RV contractility, further RV dilation, and causing further LV diastolic and systolic dysfunction via the phenomenon of ventricular interdependence. So remember, the right ventricle feels more during systole. And this gives us this thing called the RV death spiral. We can go through from here is that there'll be increase in RV afterload for various reasons that result in impedance to right ventricle outflow, and therefore right ventricle stroke volume increases. That results in terms of a reduction in right ventricle cardiac output, and therefore result in an increase in RV dimensions, and that result in a leftward shift of the interventricular septum, and that impedes left ventricle filling, result in a decrease in left ventricular cardiac output, result in a reduction in mean arterial pressure, resulting in a reduction in your coronary perfusion, and therefore result in more right ventricular ischemia. So it's a death spiral. And in critical care, it's important to realize this death spiral early, so that we can try to prevent patients from getting worse and falling into a black hole. So pulmonary hypertension and ARDS could be related to the ARDS itself because of hypoxemia, hypercapnia, or lung parenchyma destruction, or pulmonary microthrombi, and that could result in an increase in pulmonary vascular resistance. And I guess that is also of particular importance in COVID-19 because of this prothrombotic state that a lot of patients have been described to have. The other reason why patients might have pulmonary hypertension is related to what we do in the ICU in terms of our mechanical ventilation with the use of PEEP. So it's been well described that in patient acute respiratory failure, the mean pulmonary artery pressure is much higher compared to normal patients. And similarly, the pulmonary vascular resistance of patients with acute respiratory failure is much higher compared to patients with no respiratory failure. And this very important relationship shows that as your pulmonary vascular resistance increases, your cardiac index drops very fast. And therefore, it's very important to be aware of the pulmonary vascular resistance. We'll now discuss about the effect of mechanical ventilation or heart-lung interactions. So during positive pressure ventilation, there will be increase in intrathoracic pressure, and that will translate to an increase in the right atrial pressure. As described earlier on by this venous return graph, we can superimpose a cardiac function curve or the Starling's curve. And the point of intersection is the equilibrium at which the heart is operating in terms of the blood flow in the body. So when it's increased in your right atrial pressure, the Frank-Starling curve actually shifts to the right. And therefore, we are operating at a lower level, means that there's less blood flow in the body. And the way to counteract that is to give a volume infusion. You can shift back the volume venous return graph because we increase basically the mean systemic filling pressure, and therefore we are able to operate a higher level with more blood flow in the body. Therefore, RV preload actually reduces with positive pressure ventilation. The other thing is that in terms of the transpulmonary pressure will increase with positive pressure ventilation. We now discuss our effect of transpulmonary pressure on pulmonary vascular resistance. So what happens during mechanical inspiration? It's been shown that a small increase in terms of your transpulmonary pressure will result in a very rapid rise in your pulmonary vascular resistance. In fact, it's a bit of a U-shaped pattern, and just because the lowest pulmonary vascular resistance occurs actually at FRC, functional residual capacity. As the lung inflates from the residual volume to the FRC, that's resulting in a reduction in the resistance imposed by the extra-alveolar vessels. However, with lung hyperinflation towards the total lung capacity, there's going to be more contribution by your compression of alveolar vessels on your pulmonary vascular resistance. You can see it's getting smaller. And basically, we are converting from the zone 3 to the rest zone 2 because of compression of your capillaries and veins by your high intra-alveolar pressure. So in summary, for positive pressure ventilation, it's going to increase in transpulmonary pressure, compresses your intra-alveolar vessels, converting a rest zone 3 to a rest zone 1 and 2, increasing pulmonary vascular resistance, therefore increasing right ventricle afterload and dropping your cardiac index. So how can we minimize the increase in terms of intrathoracic pressure? This is a landmark study that showed a lower tidal volume than traditional tidal volume may result in better survival and also less time in terms of mechanical ventilation. However, we are not really sure what's the exact tidal volume. It may show also that if tidal volume is too low, it may also increase mortality, and that could be related in terms of the hypercapnia that we discussed earlier on. The hypercapnia can also increase pulmonary pressures. So is there a safe plateau in ARDS? So answers that we are not very certain, but it's shown in the studies that if your plateau pressure is more than 27 cm water, your risk of your acute cor pulmonale increases. And similarly, if you have acute cor pulmonale and your plateau pressure is more than 27, your chance of dying is much higher. So 27 cm water or plateau pressure appears to be a safe level, but really it's only the right heart will know what pressure it can actually handle. We've shown also not just in mechanical inspiration, but even during mechanical aspiration, if we actually use PEEP, which we use nowadays in most patients, you can see from this diagram that without PEEP, there's going to be quite a good blood flow in the pulmonary vessels. By a PEEP of 15 cm water, much of the blood flow are occluded. And therefore, even during exhalation, your PEEP also have an effect in increasing pulmonary vascular resistance. This is a very nice diagram that shows that your pulmonary vascular resistance is related to amount of PEEP. And the effect of PEEP might be averted if you have a volume bolus by passive leg risk maneuver. When you see there's PEEP increases, there's increase in the pulmonary vascular resistance with some form of fluid bolus, or in this case by passive leg risk maneuver, there's a reduction in pulmonary vascular resistance because of more venous return. And similarly, in terms of the right ventricular dilation, a higher PEEP will result in more RV dilation, and that could be averted by ensuring there's enough of fluid in patient in order to reduce the pulmonary vascular resistance. And similarly, cardiac index is going to drop if patient is preload dependent with your PEEP application. With fluid administration, we may avert the drop in the cardiac index. So in all, the PEEP itself is going to reduce pulmonary vascular resistance by reducing hypoxic pulmonary vascular constriction. That's the benefit of PEEP. However, the PEEP also can compress intra-alveolar vessels, converting zone 3 to zone 1 and 2, increasing pulmonary vascular resistance, increasing right ventricle afterload, and therefore dropping cardiac index. Whereas passive leg risk maneuver, or in terms of your fluid boluses, there's going to be increase in venous return, increased central blood volume, resulting in less intra-alveolar vessel compression, and therefore less pulmonary vascular resistance, less RV afterload, and increasing your cardiac index. Then therefore, positive pressure ventilation increases your pulmonary vascular resistance and increases your right ventricle afterload. So how do you diagnose acute cor pulmonale in the ICU? End of the day, cor pulmonale is echocardiographic diagnosis, and the right ventricle, as mentioned earlier on, is rather complex geometry compared to the left ventricle, and therefore there are more challenges in terms of quantification with size and function, and therefore it's good to rely on some international standardization. And most of us locally will use the qualification by the American Society of Echocardiography guidelines. RV size should be measured in the RV focus view, either by the basal diameter or the mid-chamber diameter, or you can now use a 3D echo to quantify the RV volume. And of course, RV wall thickness is best measured in a subcostal 4-chamber view. Most RV function, most of us use a TAPC or tricuspid annular plane systolic excursion that measures mainly the longitudinal excursion of the tricuspid annulus. So this measures a longitudinal function, but it's been compared to radial CAT scan to be comparable to the global RV function. The other way is to trace the outline of the right ventricle in diastole and systole to measure the fractional area contraction. However, the main issue is that we need to have a good right endocardial border definition in order for us to trace accurately the borders. Other ways will include Doppler imaging, of course 3D echo to measure stroke volume. Just want to say that there are more techniques nowadays available in the ICU, including speckle tracking. There's less angle dependent. It's been shown as well that if we have got pulmonary hypertension that's decompensated, there's going to be a reduction in the RV strain, which is a measure of the function of the contractility of the right ventricle. So essentially echo show some EVO clips. This is a personal long axis view, personal short axis, and also your apical 4-chamber view. Just remembering that the right ventricle will dilate in cor pulmonale, and there's going to be evidence of septatus kinesia, and together it defines what is the phenotypic echo features of acute cor pulmonale, plus honest reduction in LV size and compliance. So now we go through what should we have when you diagnose a patient as having acute cor pulmonale. I think that it's important to have continuous parameters that's reasonably continuous, reasonably objective, reasonably easy to track, and easy able to interpret. So pulmonary artery catheter, I think that is less used nowadays, but for patients with pulmonary hypertension or acute right heart failure, I think there's still a role for pulmonary artery catheter. They give us continuous pulmonary artery pressures, give us some form of pulmonary artery occlusion pressure as a marker of left atrial pressure. You can do intermittent cardiac index by a cold saline thermodilation bolus, or the more advanced PA catheter have a thermofilament that actually warms up the blood so they can generate a thermodilation curve every 2 minutes to give you some sort of continuous cardiac index. And some also have a rapidly reacting thermistor, giving us some form of continuous right ventricular end diastolic volume index. And they could be useful when patients have RV dilation, and also measuring the mid-venous oxygen saturation as a marker for perfusion. So I know the overarching concepts in ICU is about perfusion to the organs, and so our pressure versus flow versus oxygenation. We want to have a good pressure, a perfusion pressure to bring blood to the organs. We also want a good flow, and a good pressure may not always mean a good flow, especially the use of high-dose vasoconstrictors. So pressure is a map, and flow, you can use cardiac output, SCVO2 or CO2 gap. End of the day, a question to ask is, do we give fluids, do we give vasopressors, or do we give patient inotropes? I think that measuring fluid responsiveness is always a challenge in the ICU, and therefore it's very important to be aware of whether patient requires the fluids. So overarching management for acute cor pulmonale goes back to the same picture again. Because it's increased afterload, and therefore use of pulmonary vasodilators is very important, and correcting the hypoxemia and hypercapnia, optimizing our mechanical ventilatory settings. In terms of contractility, it's important to start inotropes, and even better, inotrope with pulmonary vasodilatory effects. In terms of increased end diastolic volume, diuretics or gentle ultrafiltration may be very helpful. At the end of the day, we can't emphasize enough importance of maintaining sinus freedom, avoiding tachycardia, which will further affect your LV diastolic compliance, and also try to preserve your SPP more than pulmonary artery pressure in order to improve your coronary perfusion to the right ventricle. So go through briefly the preload contractility and afterload optimization in right heart failure. Not too little volume, because we do know that fluid restriction may limit venous return, because we need a higher mean systemic filling pressure to try to overcome the resistance of the high right atrial pressure. And furthermore, hypovolemia will favor a zone 2 condition, because if intravascular pressure is low, there will be further compression of your intra-alveolar vessels by your inflated alveoli, causing increase in the pulmonary vascular resistance, as illustrated in the earlier chart as shown earlier on. And therefore, reduced central blood volume could amplify deleterious impact on mechanical ventilation and PEEP on RV afterload and RV function. So not too little volume. On the other hand, how do we know how much of volume to give? I think we are all very familiar with this diagram saying that all the static markers of preload, for example, right atrial pressure or your pulmonary arterial occlusion pressure, is not sensitive nor specific in telling us that patient is a fluid responder, and your pulse pressure variation, your systolic pressure variation, or stroke volume variation is more sensitive and specific. However, I want to just point out that all these respiratory variation indices must fulfill a few criteria, and one of them is no significant right heart dysfunction. So if the patient is acute cor pulmonale, all this respiratory variation cannot be utilized. It's been shown in this very nice study. They've shown that in a patient with right heart failure or elevated pulmonary pressures, your sensitivity and your specificity of positive of a pulse pressure variation or any other forms of respiratory variation is not accurate at all. So it's going to be very false positive because of enhanced ventricular interdependence. So you give volume because the PPV is going to be 18%. You may not necessarily improve outcome and may worsen your right ventricle afterload. So it's important to remember that. And therefore, remember that of association between pulse pressure variation and volume responsiveness in patients on high pulmonary artery pressures. And free resuscitation is associated with rapid increases in right atrial pressure should be stopped until evidence of cor pulmonale is excluded. And this is what our patient had. Remember, we give patient a fluid bolus and the central venous pressure increased from 13 to 16, and SVV actually got higher as well. However, this is also important to show that when the RV volume does increase, the effect is not just on the right heart, but also it reduces the compliance of the left ventricle because of the ventricular interdependence phenomenon. So not too much volume. If RV is dilated, free infusion, there's no increase in right ventricular stroke volume. In fact, the large increase in the right ventricular end diastolic pressure will result in terms of a drop in the left ventricular stroke volume because you shift the septum to the left. And therefore, you may also increase in RV wall stress because of high volume, causing more ischemia to the right heart. This is a very interesting study has shown that when it's going to be evidence of RV overload, you reduce the compliance of the left ventricle, okay? And if you actually remove some of the volume from the right ventricle, for example, 10 mL in this experimental study, you are going to actually improve in terms of the left ventricle compliance. So a bit of fluid removal can actually help the patient hemodynamically to get better when it's RV dilation. So fluid restriction and the cautious use of diuretics to find the sweet spot for RV filling should be done if evidence of RV volume overload is present. So this is a very nice document again showing that it's compression of the left ventricle and goes with high wedge pressure of 24 mmHg. And after even diuretics, we can see that the wedge pressure actually reduces because the left ventricular compliance improves when there's less septal shift from the right heart to the left heart. Okay, so to recap, fluids may or may not help. Overdistension will be bad. Okay, allow the right ventricle to define its required volume by continuous assessment of right ventricular size and function by echo. And if RV is dilated, gentle diuresis may help to improve hemodynamics. Just a few slides on contractility optimization. It's been shown that there's a left component to the right-sided pressure and also a left-sided component to the pulmonary blood flow. So left heart does also contribute to right heart systolic function. Similarly, this experiment shown that when it's going to be a partial aortic occlusion, there's going to be a sudden increase in your left ventricular generated pressure, and that helps also in terms of the right ventricular contractility. And that's because of the fact that more than half of the right ventricular systolic function is generated by LV contraction because of the free wall interconnection, or what we call the systolic interdependence. And therefore, any measure to improve LV contractility will also be helpful for the right heart. And it's best is to use inotrope with pulmonary vasodilatory effects, which we'll go through later on. So use of levosamander in RV dysfunction has been studied before. So the pulmonary vascular resistance actually dropped in terms of levosamander compared to placebo. And not only a drop in pulmonary vascular resistance, but there's an appreciable rise in your cardiac output and also increase in your right ventricular ejection fraction. Levosamander has also been compared with tolbutamine. So you can see in this chart that tolbutamine doesn't drop your pulmonary vascular resistance, although it does increase your cardiac contractility. On the other hand, your levosamander actually improves both your cardiac contractility and reduce your pulmonary vascular resistance because of pulmonary vasodilation. And therefore, overall, the ES over EA, which is RV to PA coupling, is actually much better with levosamander compared to tolbutamine. And that's because of the fact that tolbutamine improved only by RV contractility. RV levosamander improved RV to PA coupling by both increased RV contractility and reducing RV afterload. So a pulmonary vasodilator is what we hope to get in patients with RV failure. And similarly, after reduction is important. This slide is study the use of nitric oxide. You can see it's going to be reduction in your end diastolic volume, reduction in end systolic volume, improvement in ejection fraction of the heart, and also improvement in cardiac index. So inhaled nitric oxide decreases RV afterload by reducing pulmonary vascular resistance, leading to an increase in right ventricular ejection fraction. And the decreases in PaOP also suggest improvement in left ventricular diastolic filling when your RV dimension reduces. Another very commonly used afterload reduction agent is inhaled iloprost. So similarly, you can see from these charts over here that your normally this is your pulmonary arterial resistance. In pulmonary hypertension, it actually increases your pulmonary vascular resistance. With use of inhaled iloprost, your pulmonary vascular resistance actually go back from high to back to normal. Okay. Therefore, inhaled iloprost improve global hemodynamics, primary wire selective pulmonary vasodilation, and restoration of left ventricular preload. There may be a slight reduction in RV afterload is associated with a slight decrease in right ventricular contractility, but that's actually okay because it just means that we're operating at a lower energetic cost. So in summary, in terms of after reduction and use of inotrope, what we want is a medication that increases your right ventricular contractility, a medication that reduces your pulmonary vascular resistance, which is your RV afterload, and overall increase your effectiveness of right ventricular to your pulmonary artery coupling. Therefore, pharmacologically reduced pulmonary vascular resistance is important without causing systemic arterial hypotension with the associated detrimental effects on coronary perfusion and reflex tachycardia. So prone positioning has been very popular, especially after a Prosiva trial that showed reduced mortality. And we've shown there's also hemodynamic effects beyond just oxygenation improvement, because when it's prone positioning, there's going to be increase in intra-abdominal pressure, increasing systemic venous return, and therefore improving right ventricular preload. Similarly, there will be reduction in hypoxemia and hypoxic pulmonary vasoconstriction. There will also be more lung recruitment and overall reduction in pulmonary vascular resistance, and therefore reduction in RV afterload. So in total, a reduction in RV afterload, if improvement in RV preload will result in an improvement in LV preload, and in patients who are preload responsive, there will be improvement in your cardiac output to the heart, to the body. So we've shown this diagram that before prone position, you can see the right ventricle is quite dilated and there's a lot of septal shift, but after prone, you can see that the RV is less dilated and there's less septal dyskinesia. So in summary, prone positioning, improved oxygenation, and therefore reduction in terms of hypoxic pulmonary vasoconstriction, reducing your pulmonary vascular resistance, and therefore reduction in RV afterload, increasing your intra-abdominal pressure, increasing venous return, and therefore increasing RV preload. There might also be a concern that your intra-abdominal pressure is too high. It may also increase your left ventricle afterload. So I know that what we want is not just a lung protective strategy, but also a RV protective ventilation strategy. So for example, aim for a Pro 2 pressure that's less than 27 cm water, a driving pressure less than 17 cm water, aim for a CO2 less than 60 millimeters mercury, avoid a high PEEP, and then we use echo to quantify the RV size and function, and then we consider prone positioning if we are still having hypoxemia at day 2. So if the patient is still not doing very well, that's when we want to consider mechanical circulatory support. Just want to point out this thing called Impeller RP that's available locally. Therefore, for selected patient, it might be helpful as it can support the right ventricle. Basically, it drains blood from the IVC and push through this small SU pump into the pulmonary circulation, the Impeller RP device. So back to the patient. So this is what we had at the start, and this is what we did for our patient. We used the aquapheresis to remove some water, started some mirinone because it's an inotrope and also a pulmonary vasodilatory effect, and reduced RV afterload by using inhaled inopros. We decided to cut down norepinephrine because a high dose of norepinephrine, apart from increasing your systemic vascular resistance, it can also increase your pulmonary vascular resistance. Instead, we use more of vasopressin. And that's what we found. The MET actually got better. There's also improvement in the cardiac index. There's also a reduction in your end diastolic volume of the right heart. And of course, your central venous pressure also reduced. And the PI pressure actually got much lower after we did everything over here in terms of preload optimization, contractility optimization, and after reduction measures. And this is a very nice summary chart that shows that as a drop in terms of your right ventricular end diastolic volume, there's an increase in your cardiac index. So in summary, we went through RV anatomy and physiology. We also went through the heart-lung interactions in mechanical ventilation in terms of how it affects your RV preload and RV afterload. And the diagnosis of acute cor pulmonale relies mainly on echo features of dilatation and septal dyskinesia, and importance of considering the preload, contractility, and afterload optimization in right heart failure. So the last words will be, the humble RV has always been given less attention, but can cause trouble if completely ignored. We need not just a lung protective ventilation strategy, but also a RV protective ventilation strategy. Afterload reduction strategy is a must, coupled with optimization of RV preload and contractility. Water may not always work and may cause harm, especially when RV is dilated. Regular echo or some form of continuous monitoring is helpful. And consider MCS early in appropriate patients. And thank you very much for your attention.
Thank you very much, Dr. Chia, for taking us through this real-life patient case. And and for illustrating this very important concepts in heart-lung interactions during mechanical ventilation, and of course highlighting the RV death spiral. Since all of us here practice in the ICU and manage ventilated patients, we certainly need to pay attention to this and mitigate any unwanted consequences on the right heart. To all the attendees who have just joined us, all the talks and sessions are recorded and will be uploaded onto our website. Our website as the lobby page is also up at the moment, so do visit this. As for all the lectures, you can revisit it at the end of the session as well. In the meantime, we will answer the Q&As at the end of the sessions, and do post them in the Q&A tab below. So next up, we have our third and final speaker for the track, Professor Marcus Ong, and he'll be talking to us about out-of-hospital cardiac arrest management in the COVID era. Professor Ong is a Senior Consultant, Director of Research and Intervention Sciences at the Department of Emergency Medicine at the Singapore General Hospital. He is also the Director of the Health Services Research Centre at SingHealth Services and Professor and Director of Health Services and Systems Research with Duke NUS. Prof. Ong also serves as the Medical Director of the Units for Pre-Hospital Emergency Care under the Ministry of Health. Last but not least, he is also Chairman of the Pan-Asian Resuscitation Outcome Study. Prof. Ong's research focuses on pre-hospital emergency care and out-of-hospital cardiac arrest. He is also a clinical innovator and big data scientist. Of note is his patented invention of using heart rate variability as a risk stratification tool for chest pain patients. And he also serves as the scientific advisor at Global Healthcare, which is a startup company providing medical cooling solutions. I'll now hand the time over to Prof. Marcus Ong.
Hello, I'm Marcus Ong, and today we're going to be talking about out-of-hospital cardiac arrest management in Singapore in the COVID era. I bring you greetings from your friends in Singapore, and some of you might know we are a small nation state with a population of 5.6 million, one of the most densely populated countries in the world. And we are a major international travel hub and one of the earliest to report COVID-19 outside of China. Now, the background to this talk is that we have been collecting out-of-hospital cardiac arrest data since 2001 in a national out-of-hospital cardiac arrest registry that we call the PAROS study, the Pan-Asian Resuscitation Outcomes Study. And we've been able to layer stepwise public health and EMS interventions over the last 15 to 20 years. And in doing so, we have seen an increase in our survival for witness VF from 2% to over 20% today. And this has been through implementation of a national strategy to improve survival that spans the entire chain of survival, starting from the community where the patient collapses, emergency medical dispatch, which is 995 in Singapore, EMS and the ambulance interventions, and the interface with the hospital and the emergency department system. And so about in 2010, we actually launched a major plan that looked at the gaps that existed at that time. And we came up with 5 major strategies to address these gaps. And these included strengthening oversight and leadership, improving technology, strengthening our ambulance regulations, skills development, and a focus on increased public education and training. And we recently published in the Lancet Public Health, look at basically our out-of-hospital cardiac arrest cohort over time, and dividing the analysis into 5 phases, which was the pre-intervention phase, the EMS intervention phase, where we brought in a bundle of ambulance-based interventions in 2012, the dispatch-assisted CPR period, which was from 2012 to 2014, and then a widespread community-based education program focusing on dispatcher-assisted CPR in 2014 and 15. And finally, from 2015 onwards, bringing in community first responders through the My Responder app. So the EMS bundle of interventions included equipping fire bikers on a motorcycle with an AED, and this actually improved our response times for cardiac arrest and reduced our time to first defibrillation. We also brought in bundles such as intravenous adrenaline, supraglottic airways, mechanical CPR on board all our ambulances, as well as intraosseous needles over time. A big piece of our work was actually focused on introducing dispatcher-assisted CPR, which did not exist before in Singapore. And we started a series of DA-CPR education, weekly in-service trainings for our call center staff, as well as a very rigorous quality assurance program where we record basically all the 995 calls and review the cardiac arrest and give direct feedback to dispatchers on how to improve the delivery of dispatcher-assisted CPR. And this was linked in the third phase with a widespread community education program that we call DARE. So DARE is a simplified CPR AED training that takes less than 45 minutes and is focused on increasing awareness among the public of how to work with a dispatcher over 995, recognize cardiac arrest, start compression-only CPR, press the buttons on the defibrillator, and to remember that they just need to follow the instructions of the dispatcher. And we also link this with a public AED program where we install AEDs in all major public housing estates, as well as linked it to a national AED registry. And finally, in the last phase, we actually mobilize community first responders through adoption of an app that we built that is called My Responder. And the app has three functions. It can actually be used to alert 995 of a cardiac arrest. And if there is a volunteer first responder within 400 meters of an arrest, it will actually alert the responder, give them an option to respond, as well as show them where the nearest AED is. So let's go into the description of our cohort over time. And as you can see, the 5 phases are represented in the columns on this table. And what we saw was a dramatic increase in our bystander CPR rate from 18.7% in the pre-intervention phase up to 60.9% in the final phase with the cumulative bundle of interventions. And similarly, our overall survival to hospital discharge increased from 2.4% to 5.4% with basically almost 100 plus additional survivors per year. The other thing you will notice is that there was a background trend basically where we have an aging population in Singapore, and the median age of the population that was having an arrest was actually increasing over time. And this also is seen in the trend of the first arrest rhythm over time. And you can see that the proportion of shockable rhythm, VT or VF, actually decreased from 21% down to 18% over time, which basically also reflects on that aging population. The other thing of note in this table is that our response time more or less remains stable, but we are able to reduce this by a small proportion over a period of time. You can also see here the proportion of defibrillation more or less remains stable over time. Okay, and here we actually comparing basically the cumulative effect of our various bundles over time. And you can see that the odds ratio for receiving bystander CPR actually increased from the pre-intervention period to the first phase, second phase, and to the final phase up to a 7.66 odds ratio increase in the likelihood of receiving bystander CPR. And similarly, the odds of actually surviving to hospital discharge increased by a factor of 3.1 over the period of time with our bundles. And this is dividing that results into residential arrests that occurred in the home, versus public arrests that were non-residential. And you can see that the cumulative impact of the interventions were actually still positive in both groups. And what is of note is that the interventions were actually more effective in the residential or home arrest, with a factor of 9.9 increased odds ratio, basically of receiving bystander CPR. And we believe this is because a lot of our interventions were actually focused on increasing bystander CPR in the home. So whether that was through telephone CPR, mobilization of first responders and volunteers to the app to go into people's homes, and public education that's focused on families. These actually were able to impact our overall delivery of bystander CPR in homes. And so you can see that this is graphically the representation of the adjusted probability of receiving bystander CPR over time with our bundle of interventions. And likewise, the increased likelihood of survival by the intervention periods. So now we move over to what is the impact of COVID-19 on pre-hospital emergency care in Singapore. And the pictures here show you and give you an idea of the PPE that our EMS staff would routinely have to don during this period. And the background is that Singapore has not been spared the impact of COVID-19. Just like many countries, we actually had a wave of infections, especially among the dormitory workers that basically the migrant worker population in Singapore. So to date, we've had over 50,000 cases. But what is important to note is that we have actually been able to protect the healthcare system and treat the majority of these cases in isolation facilities within the community. And to date, the number of actual cases in isolation or in the hospital have declined dramatically, and with no ICU cases. And to date, from the beginning of January until now, we've only had 27 deaths altogether. And I think this is a good demonstration that by protecting the healthcare system and being able to continue to deliver high quality medical care, we can actually have fairly good outcomes for patients, with even a 102-year-old surviving and being able to be discharged alive from the ICU. And we actually did some simulation studies to analyze the impact of Singapore's COVID-19 strategy, which is a combination of aggressive testing, contact tracing, community-based isolation, early public health measures, including safe distancing and masking of the population, and being able to preserve hospital resources. And you can see that this is work from my group that shows that if we had not implemented a lot of these containment approaches, there could have been a magnitude of multiple factors in terms of the number of infections and the number of mortality in Singapore. How has it impacted EMS? Well, for one, we actually saw a decline in the number of EMS calls during the peak of the COVID-19 period. And this has actually now more or less increased back to our pre-COVID kind of levels now. Of note also is that the priority one, which are the most severe cases, continued to be more or less a constant. What did increase was the number of suspected COVID-19 conveyances by EMS, which actually did put some strain on the EMS system. And obviously, there was an impact on our response times as well because of the additional PPE requirements. So how has this impacted out-of-hospital cardiac arrest management in Singapore? So in this analysis, we actually took all adult EMS-attended cardiac arrest patients from the 1st of January to 31st of May, and corresponded the pandemic period in 2020 with controls from the similar period in 2018 and 2019. And we looked at basically the initial kind of outcomes of bystander CPR as well as pre-hospital return of spontaneous circulation. So I'm going to walk us through a little bit of the results. And you can see here that the background is that of an aging population with a still increasing median age of the arrest victims. And in fact, the overall number of cardiac arrests was still increasing over the 3 years from 1,200 in 2018 to 1,400 in 2020. We also saw an increase in the number of residential arrests that were treated by EMS over the COVID period, as well as an increase in the family witness arrests. And this corresponded with the increased number of residential arrests. However, you can see that bystander CPR actually declined over the period of time. And we'll go into this in more detail later on. The proportion of shockable rhythms also declined, and there was an increase in the EMS response time, and especially the scene time for the crews. And this, I think, is related to the additional requirements with PPE and the protective equipment that the staff had to actually endure. And so this is the unadjusted logistic regression and comparing the pre-pandemic and pandemic periods. And you can see again the trends that I've described, basically still an increasing age of the arrest victims, increase in the number of residential arrests, increase in witness arrests, decline in the bystander CPR, decline in the response times, and also a corresponding decrease in the pre-hospital ROSC. And when we put this through a multivariable logistic regression, you can see that ones that remain significant were the increase in residential compared to public arrests, the increase in witness arrests, the 0.7 adjusted odds ratio for reduction in bystander CPR, as well as the decline in the pre-hospital return of spontaneous circulation. However, what was encouraging for us is that we were still able to see an increase in the number of bystander AEDs applied. And this is the graphical representation of the trends. And so you can see that the blue lines are depicting that the total number of arrests was still increasing. And I think in Singapore, this is more a reflection of the overall aging population and long-term trends that we have seen in the increase over years in the number of cardiac arrest cases. We did have a few cases of thrombotic-related episodes of arrest in relatively young COVID-positive patients, but these were actually, in the overall scheme of things, very small in number. And then in the green, you can see that there was unfortunately a reversal of our trend of increasing return of spontaneous circulation, and with a decline in 2020. So in conclusion, we did see a significant impact of COVID-19 on cardiac arrest incidents, as well as a reduction in pre-hospital return of circulation in Singapore. The final part I'm going to talk about is actually staff protection. And as you know, this has been an issue not just in Southeast Asia, but the rest of the world, where significant numbers of healthcare workers have actually been infected with COVID-19 and even have died or have had severe complications from the disease. Our experience in Singapore, however, is that with adequate preparedness and early masking of our healthcare workers, we have actually not seen very many numbers of healthcare workers being infected. And this actually has been impact of our early experience with SARS more than 10 years ago. So it's actually been routine practice for me at the emergency department to have to wear a surgical mask at minimum when on shift in the emergency department. And so we were able to actually step up our protective equipment with early warning of the COVID-19 outbreak in China at that time. And this is an early case study that we published where one of the initial patients that was admitted through the EMS into the emergency department and up to the ICU actually passed through the hands of 30 to 40 healthcare workers before being detected and diagnosed as being COVID positive. And despite that, most of the healthcare workers were only wearing a surgical mask. Not a single one of them actually tested positive subsequently, which shows that even your minimum kind of PPE measures with a surgical mask and aggressive hand hygiene actually can prevent spread of infection. And so this is our current EMS PPE posture, especially for suspected cases. And we'll be happy to share more information on this for anyone who is interested. So this is a pop quiz. What's the difference between the American superhero and the Asian superhero? And you can see the main difference is that one wears the mask over their mouth and nose, and the other wears the mask over their eyes only. And so we are trying to continue to extend that concept of protection for our first responders, especially the lay first responders as well. And to date, we are still encouraging the public to do hands-only bystander CPR, and we continue to give telephone instructions and encourage compression-only CPR for the public. In addition, we have been encouraging universal masking of the population and looking at the evolving concept of a CPR protection kit that we'll place with AEDs that are available in the public. And the idea is that both the rescuer would be wearing a mask, and as well as the victim who would have a mask protecting them. Now, finally, what can we expect with COVID-19? So most of us have actually passed through the first wave of immediate mortality and morbidity directly related to disease. But what we are seeing now is the second wave, which is the impact of resource restriction on non-COVID conditions. And in fact, at the emergency department, we are seeing a return of the patients coming to the emergency department, as well as those that have delayed care or have postponed surgeries. And we expect that there will be a third wave, which is the impact of interrupted care on chronic conditions. And finally, let's not forget about the fourth wave, which is related to mental health kind of impact, social impact, and economic injury from the pandemic. So in the light of this kind of background, I think research has proven to be all the more important. And in our system in SingHealth, Duke NUS, we've actually had a very vigorous COVID-19 research response. And this is a team that I lead that has been mainly doing simulation modeling on the effectiveness of policy and public health interventions, advising healthcare resource planning at the hospital level, from allocation of isolation beds to ICU resources, looking at EMS and the impact on emergency departments, looking at the social and psychological impact on vulnerable patients, as well as the non-COVID patients, and finally looking at the economic impact of COVID-19 on the overall health system. And so a question that I'm often asked is what is going to happen in the months to come? Well, I think there are three possible scenarios of how COVID-19 could play out. Unfortunately, the first scenario of a single wave that peters out over 9 to 12 months is now looking as the least likely, and indeed very dependent on how we progress with vaccines and effective treatments. But the more likely are the two scenarios on the right, which is having repeated waves that might come in. But I think with the experience that we have gained in dealing with the first wave, we are much better prepared, and you will see a much more attenuated impact on the health system. And finally, there's the last scenario at the bottom, which is moving from an epidemic to endemic disease, where we'll actually have very low levels of COVID-19 that can flare up, and we have to be prepared to respond at any time. And so with that, let me close by sharing with you the inauguration of our pre-hospital and emergency research center at the Duke NUS Medical School. which is a multi-agency collaboration between the university, health system, and our pre-hospital providers. And hopefully, do join us in our future activities, and the website is there for you to browse. So with that, I thank you very much, and we'll be happy to take questions.
Thank you very much, Professor Ong. Thank you very much for highlighting the difficulties and workarounds of attending to the out-of-hospital cardiac arrest patients in this current pandemic. And hopefully, with even with this COVID-19 ongoing, we will not see a drop in first responder rates to our hospital cardiac arrest patients. All right, so I think we have a couple of questions in the Q&A from the audience. I believe the first two questions are directed at Dr. Chia. Thanks, Dr. Chia, for answering the second question. All right, the first question from Dr. Ong. So, is volume view transpulmonary thermal dilution accurate in right heart failure? Dr. Chia?
Hey, sorry. Yeah, thanks very much for the question. So I think that the main issue about transpulmonary thermal dilution is that it's mainly used to assess the cardiac index of the left heart. I mean, it's a heart function, but I guess it depends very much on intact right heart as well. So I think there's going to be a lot of challenges using a transpulmonary thermal dilution technique for us to assess in a patient with existing right heart dysfunction. Whilst then, we are not very certain whether it's a right heart dysfunction or left heart dysfunction that contribute to the poor cardiac output. So for patients with pre-existing right heart failure or has got pulmonary hypertension or high pulmonary vascular resistance, then I'll tend to use a pulmonary thermal dilution rather than a transpulmonary thermal dilution technique, just because there's less variables affected.
Thank you, Dr. Chia. And thanks for answering the question regarding Mirinone versus levosimendan. And I know that these two agents are actually very comparable in terms of their mechanism of actions. Both are inotropes, both are pulmonary vasodilators. But frequently, if patients are, as you mentioned, if they are acutely ill, instead of those acute and chronic heart failures, sometimes in the ICU, we tend to select Mirinone because it's also more easily titratable due to its relative shorter duration of action compared to levosimendan, which has active metabolites. And I believe that here in Singapore, cost is also a great issue, and Mirinone is also much cheaper than levosimendan. Well, I have a question for Professor Katz. Prof Katz. Hi. Yes. So I think you mentioned earlier that, and also in some of your studies, that cardiogenic shock patients tend to do better if they have access to a robust shock network, and also if they are admitted to a cardiovascular ICU as compared to if they were admitted to a non-cardiovascular ICU. I'm just wondering, especially here in the Asia Pacific region, where some of our patients or clinicians may not have such quick access to a shock network, is there any methods or protocols that can help us in this triage process so that our cardiogenic shock patients can be timely seen by the shock team and the cardiac ICU team?
Yeah, those are great questions. And I think that gets to the point that, not every institution, not every setting, not every nation is the same. And I think each hospital or healthcare system needs to look themselves in the mirror and decide how to attack the challenge of cardiogenic shock. I mean, some will be able to employ robust resources with a cardiogenic shock team and all forms of critical care delivery, and some particularly in our area, community-based hospitals, where they're not going to have access to those things, or not even be part necessarily of a shock network. And so, again, I think every institution has to sort of look at themselves, decide what resources they have, what resources are available, and what they can deliver to these patients. Otherwise, if not capable of managing these patients, have to have a robust process for getting patients to the right resources and to the right centers. And so I think that's, a challenge. And I think a lot of people, including a number of us in the United States, are working to come up with sort of a standard set of definitions for shock teams and shock networks and shock centers of excellence. And before we can even sort of develop optimal plans of care from a community and healthcare system and national level, we have to agree on some of those definitions, which has been challenging. I think, we're also, slowly understanding what parts of cardiogenic shock care make a difference and what parts don't necessarily need to be standardized because maybe they don't make as much of a difference. You brought up one point about getting patients to a specialized cardiovascular ICU. I think we're just starting to learn that probably makes a difference. In fact, we have a paper coming out in the American Heart Journal saying just that. In patients that get inappropriately triaged, for instance, to a non-cardiovascular ICU, tend to do worse and get less efficient access to the resources they need, like cardiac cath, like percutaneous coronary intervention, like mechanical support, if they're not taken care of by a team familiar with the management of cardiovascular critical illnesses. So I think that's a long-winded answer to say that we're learning how to do this, and we're trying to better understand what processes are important and what's not. And once we do and can agree on a common set of definitions and a common language, then I think we can start to test, optimal strategies for delivering care.
Thank you, Prof. Thank you, Prof. Katz. I guess the take-home message is that all of us need to have a common language and to have a clear definition, a defined process, so that everyone in the region or in the country know when and how to proceed.
Yeah.
I look forward to your paper that's going to be coming up on triaging patients to cardiovascular and non-cardiovascular ICU. All right, yeah, I know it's getting really late on your side over there. I have a question for Prof. Ong. So Prof. Ong, earlier we spoke about managing out-of-hospital cardiac arrest patients and for first responders to attend to these patients using hands-only CPR. I'm also wondering, because a lot of these first responders are members of the public, is there any way we can reassure or protect them, especially in this COVID-19 era? And do you think that we should actually promote or have greater public awareness about this?
Yeah, thanks, Ruth. Very relevant point. I think the good thing about our situation currently in Singapore is that, because of our tough kind of public health measures, you can see that the community spread is very much under control. I mean, we've practically had zero community spread for the last 2 weeks now. And so I think we have a lot of confidence to actually advise and encourage the patients that they should continue to do bystander CPR. And in fact, we have reactivated our My Responders, which we shut down for a while during the circuit breaker period. So we are now actively, again, dispatching volunteer first responders, to cardiac arrest and into homes. And I think you're absolutely right. Some public health messaging and reassurance to the public would be helpful. I think the good thing again is also we are having universal masking, which means the victim is having a mask on the face. The first responder has a mask on their face. We are not asking them to give mouth to mouth. We're asking them to do hands-only compression. And maybe the additional thing that we need to do is provide some hand sanitizers, either with the AEDs or when the ambulance crew arrive, so that people will have some kind of hand hygiene. But otherwise, I think the benefit of actually providing bystander CPR and especially early defibrillation with the public access defibrillators far outweighs the risk that anyone would contract COVID or even have complications from COVID.
Thank you very much, Prof. I think those are very relevant and pertinent points. I think the take-home message for me really is to remember to protect myself as well, to mask up the arrested patients if I do come across them. And I think you have a very robust also pre-emergency network, so the ambulance service providers can, I guess, always give these instructions even on the app or over the phone. So thank you everyone for joining us today, and to all the attendees who have just come in. If you have any questions, do let us know on our social media networks, and we will of course get back to you with regards to any answers. I want to thank my speakers once again, Prof. Katz for joining us in US, Dr. Chia, and Professor Ong for joining us this morning here. Thank you very much, and I think our website is up. If you have any further questions or any technical difficulties, do let us know, and we will get back to you as soon as we can. Thank you, everyone.
Thank you.
Yeah.